Welcome to AETCM. Today we're going to discuss a case about a 48-year-old female who came to our ER with complaints of abdominal distension for past 1 week with associated melena since the past 2 days. Shall we begin, sir? Sir, on initial assessment, the patient was conscious oriented, obeying to commands and was able to complete one full sentence. Coming to airway was patent, no secretions were noted and C-spine was normal. In breathing, air entry was bilaterally equal, a respiratory rate of 20 per minute and saturation of 96% maintained in room air. In circulation part, heart rate was 77 per minute and BP of 110/60 was present. Peripheral pulses were palpable, and in disability, GCS score was full and pupil was bilaterally 3 mm equally reactive. In exposure pass, temperature was afebrile and patient was covered to prevent hypothermia. In adjuncts to primary survey, GRBS was 98 mg per deciliter and VBG showed no acid-base derangement. The hemoglobin was 11.5 in ABG and bilirubin was 18.1. Creatinine was 1.7 and lactate was 2.7.
What type of bilirubinemia it is? Direct or indirect? Bilirubin is very high. Direct.
If total bilirubin, if direct bilirubin is too high, it is unconjugated. That is indirect. If it is total bilirubin,
No. Here what is whether it is indirect bilirubin or direct is elevated in the lab investigation. That is very important. Why it is important?
To know whether it's
hemolysis.
Whether it is hemolytic anemia or anemia induced bilirubin elevation or it is due to liver disease. Both are possible in your case.
An ECG was taken which was showed normal sinus rhythm with heart rate of 71. Sir,
In the case of ascites, what ECG change you get normally? Low voltage form because of pericardial effusion. Many patients will have pericardial effusion, pleural effusion. So low voltage complex is very, very important.
In secondary survey, sir, patient was a 48-year-old female, known case of CLD with portal hypertension, Wilson's disease, esophageal varices were present.
What are the other causes for chronic liver disease in a young female? Other causes. Wilson disease is one important cause. Then
Ethanol.
Female patient ethanol can be there, but other causes. If you tell ethanol is the first cause, then it will not be correct.
Hepatitis.
Okay, viral hepatitis. Autoimmune hepatitis, that is very important. Viral hepatitis is one entity, autoimmune hepatitis is another important problem. Okay, so Wilson disease, autoimmune hepatitis, viral hepatitis. Whereas in males, it is more of alcoholic liver disease, viral hepatitis, and autoimmune hepatitis is very, very rare in male patients. Okay.
And she was also having type 2 diabetes and hypertension. She complains of abdominal pain since the past 2 weeks with bilateral pitting pedal edema and also give history of melena for the last 2 days. There was no history of any constipation, fever, abdominal pain, hematemesis. And on general examination,
what is the importance of constipation history in all these patients, liver disease patients?
Patient can have constipation can give to increase ammonia levels, which can go on to have hepatic engulf.
Okay, trigger for hepatic engulf.
And in general examination, she was moderately built and nourished. Icterus was present and bilateral pectin pedal edema was there. Pulse rate of 96 per minute was noted and BP of...
What is the importance of pulse rate in a case of jaundice? Pulse. Is it important? Not important. Very important. What happens in obstructive jaundice for pulse? There will be bradycardia. Bradycardia is a feature of obstructive jaundice. Bilirubin acts on the SA node.
So BP of 100/60 was noted and saturation of 96% in room air and respiratory rate of 20 per minute. In systemic examination, GIT, per abdomen was distended, soft, non-tender, and bowel sounds were present, sir. And CNS examination, patient was conscious oriented. There was flapping tremor was noted and GCS was full. Other systems were within normal limit. and we did the routine lab investigations, which showed total count of 8,000, which he
What CNS abnormalities you get in hepatic encephalopathy? Early phases.
patient can have forgetfulness,
Reversible sleep cycle.
Altered sleep rhythm. Then apraxia. What is apraxia?
Constructional apraxia, where the patient is not able to do the simple
So known
activities,
things like
known
you are
things.
buttoning a shirt or some matchstick arrangement,
Daily
daily activity, that they'll forget. That is one of the earliest CNS finding. But flapping tremor is the most obvious sign. Okay.
and lab investigation were sensor, which showed total
So what
count.
is your clinical diagnosis before going to lab investigation? What you are expecting in this patient, or what all things you want to know?
Hepatic enco.
You have a patient who is having chronic liver disease and suspected early phase of hepatic encephalopathy. Flapping tremor is there, then possibly it is grade 2. Okay. So you want to investigate for that. What all things you want to rule out? Why should she go to the hepatic encephalopathy now? She is not having constipation. So hypokalemia. Then,
Her diet, basically,
Diet.
high protein diet.
so is she taking any high protein diet now?
She was taking, but not
So you don't know. So you want to rule out a high protein diet induced problem. Then what?
Infection.
Infection is very important. Anybody going to hepatic encephalopathy in a patient who is having chronic liver disease, first thing is infection. Okay, so infection, hypokalemia, then like you told, any high protein diet. Okay, how do you investigate?
potassium value should be
What is the potassium value in this patient?
here. The potassium value was
5.2.
That means hyperkalemia. So what do you do? Potassium is high. What do you do?
Take an ECG, rule out
Take an ECG and rule out
any
electrolyte imbalance.
The cardiac rhythm.
If nothing is there, what is the next step in potassium?
It could be pseudo hyperkalemia.
So repeat the sample. Okay. So don't treat hyperkalemia without any major renal disease or rhabdomyolysis. It is not going to produce any problem. It is a spurious type of hyperkalemia. Okay. So don't treat the hyperkalemia. Treat the patient. Okay. Most of the time, what we see is high potassium. Immediately give calcium gluconate, insulin dextrose infusion. It's all unnecessarily. Okay. So potassium is slightly higher. Okay.
Then the other thing is to get a total counts to rule out any infection.
What is the total count?
8,000.
So that doesn't increase. It is not showing any infection. Can you rule out infection?
No.
Yes.
Why?
No, we cannot rule out infection
Why?
because sometimes counts can be normal and the patient can have an
So in a
infection.
patient who is having immunocompromised status like liver disease, his bone marrow is suppressed because of the toxins. So there may not be any response, adequate response from the bone marrow. So counts will not tell you that there is an infection or not. Okay, but however, we have to see that counts.
Then CRP values can be
How much is the CRP?
19.
So it's slightly elevated. Then
Albumin has to be
Albumin
serum albumin. What is the albumin?
2.2.
So that is low. Okay, then
Then platelet counts
what is the platelet count?
41,000.
So it is low. Why platelet counts are low in liver disease?
Platelet segregation in spleen occurs.
Splenomegaly. Portal hypertension, splenomegaly, destruction of platelets. Then what else? What you done?
Then
we sent for an autoimmune panel and we ruled out any
and
Why? You have already proven that it is. It is already proven that patient is in Wilson disease. Why again autoimmune disease?
Then you'll have to just check for ceruloplasmin levels.
Okay, you have to see the ceruloplasmin and copper level, urine copper and liver copper, all are done previously. Now your problem is hepatic encephalopathy. You have done some investigation to rule out infection, hypokalemia. Then you want to do ammonia?
ammonia. Yes, sir. Ammonia 2 rule. Ammonia was also
One is elevated?
no.
Not elevated. Okay, so it is the hepatic encephalopathy is not due to ammonia. Okay, then
Then OST, OTPT values.
But ammonia is only one reason for hepatic encephalopathy. There are other things like mercaptans, GABA, so many other things are there. Okay.
Uh, SGOT-PT was OT was 120 and PT was 60.
Okay.
Then bilirubin values should be
Very
known.
high.
High.
Okay. PTNR,
PTNR was
INR,
INR 2.54,
it is elevated. Okay.
which
Do you have any previous values to compare?
previous,
Initially it was 2.54, and
which
the next
later
value is 2.9.
2.9
2.9. It increased.
increase.
Okay.
And
Now, what is your diagnosis? Now you got some What is the ABG value? Arterial blood gas.
ABG, ABG,
No acid-base
no
derangement,
acid
with a
base.
pH of 7.39, bicarbonate of 23, with a PCO2 of 37.7, no hypoxemia seen.
Okay. If suppose your potassium is very high, what will be the pH value?
Potassium generally comes in conjunction with acidosis. If hyperkalemia is generally seen in conjunction with uh, um, acidosis.
Okay.
But if the patient has respiratory alkalosis, or if the patient has hypokalemia, then patient can have respiratory muscles will not be contracting well, so the patient can end up with respiratory acidosis there.
Okay.
But in CLD, most commonly what we see is a respiratory alkalosis.
Respiratory alkalosis. Okay. So ABG is also normal.
And repeat potassium values. Potassium was 4.4.
Okay. That's normal. How do you manage this case in emergency room? You know that the patient is having Wilson disease and now she has come with hepatic encephalopathy. We didn't get a reason for the hepatic encephalopathy, but one of the most common cause for hepatic encephalopathy is
Infection.
Infection in the abdomen, that is
SBP.
SBP, spontaneous bacterial peritonitis. Can they have abdominal pain? Is it a must?
Yeah.
It's not necessary.
It's not necessary. It is not a must that patient should have symptoms like abdominal pain, tenderness. Nothing will be there. Vague pains may be the only clinical finding, and they'll have findings of infection. Okay. How do you manage this case?
For prevention of further worsening of hepatic engulf, we should give stool softeners.
Stool softener is not the correct word.
Laxatives.
Gut sterilizers.
Gut sterilizers.
What are the gut sterilizers? One is your laxative. Which laxative is a gut sterilizer? Here in this condition.
Lactulose.
Lactulose. Okay, it reduces the pH and reduces the number of bacteria which produces ammonia. Then rifaximin. What is a rifaximin?
Rifaximin is again a gut sterilizer, so it doesn't have any antibiotic activity.
It's a non-absorbable antibiotic. It's an antibiotic. It's a non-absorbable antibiotic. So you give rifaximin with the lactulose that sterilizes your gut. Okay. Then, but you are suspecting an infection in the. You have to give IV antibiotic. What IV antibiotic you prefer?
Something that covers the gram-negative bacteria.
Okay. Which is a common bacteria?
E. coli.
E. coli. Then what is the antibiotic you give?
We can give with anything cephalus
third generation. Ceftriaxone, cefotaxime, cefoperazone, sulbactam. Anything can be given. Okay,
Then
IV antibiotics and reassessments of.
He has got some other problem. He has got low platelet. He has got bleeding tendency.
FFPs.
FFP. How much FFP you want to give? Give 2.9 is the INR. 1 pint.
1 SDP.
15 ml per kg. That is a dose. That will correct your problem. Okay. At least 3-4 bags you have to give. That much you have to give. Okay. So FFP has to be given. Then vitamin K.
Vitamin K, no role.
There is no role. Only in obstructive jaundice, vitamin K has got a role. Here there is no role, but you can still give vitamin K. Okay. Then platelets should be treated. This patient is having 49,000.
Unless there's a bleeding manifestation.
Okay. So if it is not required here, because there is no bleeding manifestation. You correct the FFP, then itself the bleeding manifestation will subside. Then what else?
Then any hemodynamic parameters have to be serially assessed.
This patient is
The
having
patient-
hypotension.
if the
BP is
patient-
low. How do you manage?
So it's basic.
So, for management of hypertension, we can give FFPs.
No. This patient, why should he develop hypotension in ER? She has developed hypotension.
Yes, sir.
Initially BP was normal, then she
Then
developed
developed
hypotension.
Be a third space
Third
It's a
loss.
third
loss.
space loss of fluid. Okay. Either you give normal saline, but the problem with normal saline, it will be shifted to again the third space. It will go to the ascites area, and again patient will go to hypotension. So the better choice will be
Colloid,
colloid. What is a colloid?
albumin.
So you have to give albumin if possible. Only thing is it's very costly, but possible you give albumin. Okay. With what? Albumin is given. Then
Antibiotics have to be given.
antibiotics are already given. Noradrenaline with terlipressin. Okay, that is a treatment here. Albumin, noradrenaline, terlipressin. That will improve the BP. Otherwise, patient will go to hepatorenal syndrome because your albumin is low, patient is losing water. Even if you correct the infection part, patient will develop renal failure. It is not hepatorenal syndrome. It's a problem produced by the hypotension. Okay, then. Wilson disease you want to treat? Normally we don't treat. From our side we don't treat. But the treatment is depenicillamine. Depenicillamine, not liver transplantation. Liver transplantation is a last resort. You are not able to control the problem, then only you can treat. Okay, depenicillamine is the treatment of choice in Wilson disease. Okay. Now another part of Wilson disease which can come to ER is altered behavior. You have to manage that. How do you manage? Your management of
In that case, you can go with a combination of haloperidol and procyclidine.
See, the selection of the agent, don't select any long-acting drugs. Number two, no drug you are selecting should be causing any further hepatotoxic effect. So you have to keep in mind that prolonged duration of action and exaggerated response to the drugs. So in that case, when you want to go for a benzodiazepine, midazolam is an ideal. Short-acting. That in a minimal dosage and titrated dosage you give. And if you want to repeat the dosage, wait for a longer period. When the effect wears off or about to wear off, then you can repeat it. That is the most important thing to keep in mind. So other diazepam, lorazepam and all will be longer acting and we do not. Pardon?
Haloperidol can
So that's an ideal. Regarding RSI, induction agents, muscle laxants, what is the choices? Again the same thing. Avoid whichever causes hepatotoxic, right? So the most important thing throughout the thing you have to keep in mind that no hypotension is allowed. That will worsen the already existing liver damage more. So ideally is very shortest and quickest recovery is propofol and etomidate. With relaxants and opioids and other narcotic drugs mostly metabolized in the liver. So
atracurium would be half months degradation happens.
cisatracurium and atracurium, both we can go for it. And succinylcholine, if there is no other contraindication. That is also how it is metabolized. Pseudocholinesterase. It doesn't depend upon the liver for its metabolism. Most of the muscle action depend upon the liver for metabolic activity. Avoid hypotension. And another thing is autonomic imbalance may be there. So pre-hand you check for the orthostatic in BP and other things. Even in the beginning itself, there are positional changes causes any hypotension. That also keep in mind. Okay.
how was the patient after that?
Patient initially had a BP in the lower side, which later on went to below normal hypotensive state. which in turn we corrected with albumin and noradrenaline support was given.
Okay.
Later on, patient is improving right now. Patient has been weaned off of the noradrenaline support.
Okay.
Patient is improving right now.
Okay. Liver biopsy is done in the past.
Liver biopsy already done.
Okay. Only thing they have to start on
Penicillamine.
family history. Any family history may be there.
High chance of family history
Is there? It can be there, but we have not taken any history. Okay. Okay. Anything else you want to add? Wilson disease.
Yes, sir. Usually in Wilson disease, the treatment include penicillamine, triandine, ammonium tetrathiomolybdate, and also zinc can be added.
Okay.
The penicillamine and triandine are copper chelators, which capture the coppers, and high copper can be removed.
Okay.
As such, the zinc and molybdenate decrease the absorption of copper from the gut. So, also in liver failure is one of the associated complaints which can occur in Wilson's disease, which can be we should rule out, and the treatment of the liver failure will be most probably will have to do liver transplantation. And also there's a scoring system for the Wilson disease, which is called lipid scoring system, which uses various parameters which include KF ring, Kaiser-Fleischer ring, and neurological.
KF ring can we see here in ER?
No, sir.
We cannot directly see. We have to take the help of ophthalmologist with a slit lamp. Okay.
Then neurological symptoms. The scoring system points are given maximum of 2 for one system, and 2 and 1 0 going downwards, like that. KF ring is there. Neurological symptoms, ceruloplasmin levels, and hemolytic anemia, liver copper and urine copper. Then ATP7B defect. ATP7B defect is the one.
This hemolytic anemia is immune mediated or non-immune?
Coombs negative.
That means non-immune mediated.
Then to look out for the ATP7B defect, which is the defect seen in Wilson's disease, which in turn cause the ceruloplasmin binding won't be occurring due to ATP7B defect. And also according to this, we'll get the total number of points, which in turn we can divide the patients into diagnosis of Wilson or not. A score more than 4, we will get a diagnosis of Wilson's, and score less than 2, we'll have to look for alternate diagnosis.
Okay.
Yes, sir.
So here liver biopsy is the confirmatory test that has to be done. Okay. Thank you.